Thank you all for joining us today. Today we have Muhammad Al-Janabi, MD, attended medical school at Al Mustansariya in Iraq. They then completed an internship and residency at Texas Tech University. He also completed a fellowship at Vedant Medical Center. Dr. Al-Janabi is currently the Vice Chair of Critical Care at Sharp Grossman Hospital. Fadi Aadad, MD, FIDSA, is a highly skilled physician with over 20 years of experience in the medical field, specializing in infectious diseases. He's the epidemiologist and head of the Antimicrobial Stewardship Program at Sharp Grossman Hospital. He completed residency in internal medicine in 2001 at Englewood Hospital and Medical Center in Englewood, New Jersey, and completed his fellowship in infectious diseases in 2003 at New York Medical College, Valhalla, New York. He founded the Fecal Microbiota Transplant Program at Sharp Grossman Hospital. And Luke Roy, MSN, FNP, CN. Luke Roy is a board-certified family nurse practitioner, currently in the role of sepsis nurse practitioner at Sharp Grossman Hospital. In addition to providing and managing direct care of sepsis and infectious disease patients, this role includes planning, directing, and coordinating the development and implementation of initiatives to reduce mortality and improve outcomes among patients with sepsis. Luke graduated from Azusa Pacific University with a Master's of Science in Nursing Family Nurse Practitioner degree with honors in 2018. At Sharp Grossman Hospital, Luke chairs the Sepsis Task Force and Sepsis Champion Groups. Gentlemen, the floor is yours.
Thank you. Thank you. Welcome, everyone. I will go ahead and start us off. Our objectives today is to review the burden of sepsis as a critical public health challenge, identify their criteria for sepsis, severe sepsis, and shock, describe the shock early management bundle and severe sepsis early management bundle, review a case study of severe sepsis due to MRSA bacteremia, illustrate the importance of specialty consultation in complex cases, and then share indicators for readiness for discharge in the sepsis population. We have no financial disclosures related to this presentation. And our quote for today is, you treat a disease, you win, you lose. You treat a person, I guarantee you, you will win no matter what the outcome, by Patch Adams. So I wanted to just highlight that really sepsis is unbiased when we think about it. It affects all people of all shapes and sizes. Muhammad Ali had septic shock due to pneumonia. That was his cause of death. Larry King died of complications after COVID due to sepsis. Christopher Reeve, otherwise known as the first Superman, he had an infected decubitus ulcer, and that's what his source of sepsis and infection was. Both Pope John Paul II and Bill Clinton both had sepsis due to UTI, and many others here you can all see were affected by sepsis. So what is it? It's a very old problem. It started in the Greek word sepo, which means I rot. It reflects the ancient observation of putrefaction, or the rotting of flesh, accompanied by other foul odors. It was identified in Homer and some of his writings, and the warriors wounded in battle, they often died from infections, and this was noted in his writings. Hippocrates also believed that disease was caused by imbalances in the four humors: blood, phlegm, yellow bile, and black bile. And sepsis was interpreted as a result of this imbalance, especially when there was bad blood or corrupted humors. So kind of going forward to today, that was more of an environmental cue to causing infection. We currently have a definition from Singer, which is life-threatening organ dysfunction caused by a dysregulated host response to infection. There's many risk factors that can cause sepsis: age, the very young, the very old, many chronic illnesses such as diabetes, folks who are immunosuppressed, those who struggle with HIV, who are chronic steroids, patients who have cancer, recent surgery, burns, folks who are high healthcare utilizers, pregnancy, people with chronic indwelling catheters or PICC lines. A previous diagnosis of sepsis increases your risk by 50% in some cases. So when we think about the pathophysiology, really it occurs when the body's immune response is overactive to an infection, and it becomes uncontrolled and dysregulated for reasons that we still don't fully understand. This that causes harm to normal tissues and leads to massive systemic inflammation. It can be triggered by many various infections, such as bacteria, fungus, viruses, with bacteria being the most common causative pathogen. Not all infections cause sepsis, but any infection may lead to sepsis if the body's response is dysregulated in nature. And if not caught early, sepsis leads to end organ damage, with acute kidney injury being one of the most common organ dysfunctions. If we don't treat it early, it does lead to septic shock, which is a distributive form of shock that results in multi-organ failure and has a very high burden of mortality. The clinical concern is oftentimes when they present, it could be many different other things. As you can see, sepsis overlaps with things like pancreatitis, heat injury, DKA, pancreatitis, pulmonary emboli, bowel obstruction, certain medications, including HIV medications, diabetes medications, may show us indicators that patient may be septic, showing us things like high lactate or fever, etc. So it's really important to identify early and treat, and then get cultures to make sure that these patients are identified with pathogens. When we think about mortality, I found this quote by the vice president of the Global Sepsis Alliance, Dr. Narajan Tex-Kisson. And he's really talking about action that needs to be done by global health policymakers, clinicians, and researchers, because that does affect our most vulnerable populations, such as newborns, children, and the elderly. We can see that our death toll in California for 2021, mind you, this was during the pandemic, was over 30,000 patients. In the US in 2023, there's around 350 people who passed away from sepsis, and then globally, 11 million in 2024. So this really does have a high disease burden. So it is a leading cause of death, readmission, and there's a high healthcare cost associated with it. There's almost 49 million people diagnosed annually around the globe. Most cases are community onset, so this really highlights the importance of early recognition in emergency departments. Also, we do have concern for antimicrobial resistance. It is on the rise, so this makes treatment challenging. Also, something to know that many patients who survive sepsis have long-term deficits afterwards, involving cognitive, physical, and mental disabilities. Here at Grossmont, we treated over 1,600 patients with severe sepsis and septic shock last year. And really our goal at SHARP across the system is to reduce sepsis and pneumonia-related mortality and readmissions. There was an interesting study that was brought forth by the Agency for Healthcare Research and Quality to Congress that really demonstrated this healthcare burden, public health burden of sepsis. They found that sepsis-related inpatient stays increased by 40% from 2016 to 2021, and the cost of care skyrocketed by $20.9 billion in that same time frame. And sadly, higher disease burden was found in rural areas, socially vulnerable communities, and also especially among non-white and racial and ethnic minorities. So when we think about how the impact of implicit bias affects patients with sepsis, we have to first understand what implicit bias means, and that is unconscious attitudes or stereotypes that can affect an individual's understanding, actions, and decisions without their awareness. So in healthcare, marginalized groups often receive substandard care. We did find one study by Wang et al. That showed non-white ICU septic patients are at 79% higher risk of mortality compared to to white patients. So when we think about ethnicity and race, we do find that patients may be less likely to be triaged as high acuity in the ED with underdocumented pain. And also patients who struggle with substance use disorder, clinicians may assume sepsis is a direct result of drug use, leading to reduced empathy or urgency in care. So the impact of this does really lead to underestimation of severity of illness, and it may lead to delayed recognition and treatment or specialized diagnosis such as echoes, which increases that risk of mortality. So The first thing that we can do is to just increase our awareness that implicit bias exists, whether we know it or not. Really make sure that our care is patient-centered, and also having standardized criteria and treatment for sepsis. Celebrating our diversity in our patients and amongst clinicians, and embracing our differences. So kind of speaking to the antimicrobial resistance, wanted to just share the United Nations declared that AMR, or antimicrobial resistance, is a fundamental threat to human health and security, and that was back in 2016, almost 10 years ago. It's really an escalating incidence worldwide of both sepsis and AMR. So it makes treatment for sepsis challenging. So particularly in the ICU, we have cases of E. coli and Klebsiella. If they have resistance patterns, this does cause issues with treatment and increase in mortality. There was one study that showed a 51% rate of antimicrobial resistance infections in ICU patients with higher rates of mortality, an increase of 9.9 in severe sepsis cases and 28.6 in septic shock cases, just due to the drug resistance. So how do we combat this? There's an urgent need for rapid diagnostics. What we have here at Sharp is called Verigene. It's a rapid multiplex molecular DNA diagnostic that rapidly identifies pathogens and key resistant genes. It's a very fast turnaround. So in this case, we were able to see that this patient has a gene that may represent that the patient has MRSA bacteremia. So this is very helpful for clinicians. So what do we have for guidance from our antimicrobial stewardship team? We really want to make sure that we initially and ongoing review cultures to optimize antibiotic therapy and duration, and really reassess if we need antibiotics to be narrowed at 48 to 72 hours once they have good clinical response and good source control, and then reviewing those sensitivities. Most patients, 7 days is a standard of care for sepsis from source control if the case is uncomplicated. Longer durations warrant an ID consultation. We should consider discontinuing antibiotics once an infection has been ruled out. And this is because antimicrobial resistance is increasing due to those prolonged durations of therapy. If there's no alternative diagnosis and cultures are negative, then ideally we want to reduce our antimicrobial use. One thing to know, staph usually grows within the first 48 hours, so that MRSA PCR helps reduce or de-escalate vancomycin quickly. And then also procalcitonin can help guide discontinuation after a reasonable source-based course. What do we have available here at Grossmont and across Sharp? We do have, if you go in Epic, you can go to ASP, and that has various guidelines. It gives you recommendations for antibiotic recommendations based off of the source that you're concerned about. So community-acquired or health-acquired pneumonia, for example. So please use this resource. It's available for you for free. So just some quick recent advancements that I'd like to share. So back in the 60s, Dr. Edward Frank was a vascular surgeon from Beth Israel Hospital who found that there was improved outcomes in septic patients who had frequent senior intensivist care with CVP, cardiac output monitoring, hemodynamic monitoring, daily EBGs, and those who had corrected hypovolemia, acid-base treatment, and treating the infection, as well as trached patients for ongoing respiratory failure. This did have good outcomes. However, hospitals were not able to accommodate it due to cost of care and its operational complexity. In 2002, there was a landmark study by Emmanuel Rivers that showed early goal-directed therapy did have that 16% risk reduction when we gave 30 per kilo. However, there was concern about giving many patients central lines, which increased their risk for hospital-acquired infections. In 2015, we started to have SEP1, which is our early management bundle, which is tied to our star rating. Unfortunately, this did have low compliance up front because it is an all or nothing metric. National compliance for hospitals was 54% when it first started. And then in 2024, that National Quality Forum recommended that CMS incorporate the septic shock bundle or SEP1 into value-based purchasing programs starting 2026. So that means hospitals will now be receiving or not receiving payment adjustments by CMS if they are high or low performing on SEP1. So that means most hospitals now are investing into a sepsis program. So that really means they need to have a multidisciplinary team focused on an integrated approach to that early recognition, treatment, and identifying goals and treatment for patients to improve outcomes. So what are the criteria? So according to SHARP, sepsis really requires us to have a sick or toxic appearing patient. There are criteria for SIRS, which include temperature, so low or high, less than 36, greater than 38.3, heart rate greater than 90, respiratory rate greater than 20, leukopenia or leukocytosis or bandemia greater than 10%. Severe sepsis would be infection plus 2 SIRS plus one of these organ dysfunctions. I'll just highlight some of them that sometimes are missed. One, if the patient's not on anticoagulants and their INR is greater than 1.5, that would count as organ dysfunction. Billy greater than 2, not due to another cause, or altered mental status. And then lactate greater than 2 is really severe sepsis. According to our definitions here at SHARP, septic shock would be lactate 4 or greater, regardless of hypotension or hypotension in itself, or pressors to maintain a MAP greater than 65. For our severe sepsis criteria, as I mentioned before, that's what this is. So again, infection, 2 SIRS plus 1 or more organ dysfunctions would be severe sepsis. Many people have a question about what time 0 is. That's really the earliest time the patient meets these criteria or the time of the provider diagnosis. When we think about septic shock criteria, again, it's the earliest time the patient meets criteria or the provider diagnoses the patient. And again, we think about hypotension or lactated 4 greater or pressors to maintain that NAP of 65 or greater, or in the provider diagnosis, septic shock, and that's the criteria. For treatment, it's really similar. So for the 3-hour bundle, we want to make sure we get a lactate cultures, IV antibiotics before we get blood cultures, and then 30 per kilo if the patient has hypotension. Within 6 hours, we need to get a repeat lactate if the initial's greater than 2. For septic shock, it's all of the same, except we need to give 30 per kilo in most cases, and then document blood pressures in the hour after that bolus to make sure that they don't have persistent hypotension. Repeat the lactate if the initial is greater than 2. Document a septic shock reassessment, and then give pressors for persistent hypotension. And just to call out, initial hypotension is at least 2 low blood pressures within 3 hours of presentation. So comment on SEP1, it's one of the most complex quality metrics. It's widely considered very challenging for most clinicians. This is why most hospitals have a team to help support our clinicians in sepsis, not only quality-wise, but also clinically. This is a composite all or nothing measure, so we have to get all components correct in order to pass the measure. The national average for currently for this measure is 63, and in California we're at 67. The ways to pass this measure is using our sepsis order set that we have here in-house in Epic. Some hospitals, including Grossmont, use code sepsis activation, and also making sure appropriate documentation is in the chart. Those are all major drivers of success. So some best practices, all patients should be screened. Sepsis is a medical emergency. Starting antibiotics within 1 hour of recognition time after we get cultures and an identified source of infection. Again, using the order set, obtaining cultures prior to the broad spectrum therapy. 30 per kilo is indicated in most instances of septic shock unless there's a risk for fluid overload. Using dynamic measures to guide fluid resuscitation, things like a passive leg raise, We use something called a NICOM, which is non-invasive cardiac output monitoring. Vasopressors for persistent hypotension, or for those who are not fluid responsive. Rapid source control, so draining the abscess, removing the stone. Discontinuing empiric antibiotics if there's an alternative diagnosis established. Providing patient education on admission daily and on discharge, and then early goals of care discussion to guide patient-centered care. All right, so now we're going to go through a case study, and I'm going to hand it over to Dr. Al-Janabi.
Thank you, Luke. Good afternoon, everyone. So this is one patient I admitted to the ICU, and this is just an example of what we see every day in the emergency room and admission to the ICU. He's a 37-year-old male, past medical history of asthma, severe persistent, history of eosinophilic esophagitis requiring multiple EGDs and esophageal dilatation. Came into the ED due to altered mental status. He was severely delirious, agitated. He was restrained in the ED with 4-point restraints and was requiring sedation with Precedex, Dexmed, etomidate. He was in usual state of health. He's, again, previously healthy, other than the asthma and the eosinophilic esophagitis, which is well managed and treated. And all of a sudden, start having nausea and recurrent vomiting with diarrhea, and this progressed into confusion, disorientation, and came into the ED. He was tachycardic, tachypneic, his temperature was 40 degrees, and there was a suspicion for meningitis. So, the sepsis workup was done, and I will go to the labs. We'll go to the next slide. Again, just a background on him, past medical history. He has severe persistent asthma. He has eosinophilic esophagitis, history of appendectomy, splenic repair. We investigated further. He had a cyst on his spleen, was drained, and there was nothing significant. No history of tobacco smoking, no alcohol or substance use. Again, he lives with his mother, spouse, and children. Nothing significant or related in family history, no recent travel, allergies related to asthma. His home medications include albuterol inhaler, Spiriva inhaler, that's and then Dupixent, which is dupilumab. This is approved treatment for severe persistent asthma. These are injections, anti-interleukin 4. And the review of system, he had the fever, the GI symptoms, and the altered mental status. Next slide. So initial vitals, his blood pressure initially, as you see, is normal, 124/77. He was tachycardic, heart rate up to 140s, tachypneic, febrile. On exam, looked well nourished, no signs of trauma. Pupils equal. He was tachypneic, clear lungs on exam. His abdominal exam, his abdomen was soft, no organomegaly, no tenderness or rebound tenderness. Again, he was sedated. He was given some medication to calm him down with the restraints. So neuro exam is limited, but no neck stiffness, no meningeal signs on exam. Next. This is the timeline from when the patient came into the ED until he got admitted to the ICU. So 1613 arrived, agitated and 4-point restraints with altered mental status and fever, suspected sepsis with possible source of infection, either GI or CNS. And then 1835, sepsis order set initiated and sepsis code was activated. We obtained a blood culture, check lactate, procalcitonin, a complete blood count and comprehensive metabolic panel with the COAC panel. 1945, he already received 2 liters bolus normal saline, and he had ceftriaxone. And then, again, due to the suspicion of meningitis, antibiotics were escalated to vancomycin and acyclovir. And at 22:55, Within almost 6 hours, patient was seen by the intensivist and was admitted to the ICU and had re-evaluation then. So on initial assessment, this is severe sepsis. He's not in shock state yet. Possible meningitis, gastroenteritis. He's encephalopathic. Probably this is metabolic. He was hypovolemic. His creatinine was elevated. He was not making urine at that point. So acute kidney injury. He has significant electrolyte derangement, as we will see on his lab results, hyponatremia, hypomagnesemia, had elevated liver enzymes, elevated troponin, no acute STT changes on the EKG other than the sinus tachycardia on the EKG, has elevated D-dimer and elevated INR. So this is again like a timeline, time of diagnosis 2030. He had septic shock reassessment, sepsis bundle applied, meaning resuscitated with IV fluid. Cultures were sent. Initially, he received ceftriaxone. Some further testing was done, HIV and hepatitis panel, COVID test and influenza test initially negative, and just covered empirically initially with ceftriaxone and then escalated to meningitis coverage. Next. We'll start with his labs, just looking at the right side of the screen. This is something I would like to bring your attention to. His white cell count is normal, which you would see or you would think someone doesn't have an infection with normal white cell count. But if you look at the differential, he had 48% bands, and this is significant. This meets the criteria for sepsis or SIRS. And then on the chemistry profile, the hyponatremia, hypokalemia, hypochloremia, low bicarb level, probably from the GI loss, and elevated liver enzymes, significantly elevated bilirubin at 4.2, elevated troponin at 168, which is really high, and then INR of 2, and the coagulation panel, as you see, elevated D-dimer, fibrinogen. Inflammatory markers, his ESR and CRP was significantly elevated, and the lactate was 2.2. Procalcitonin, which is a marker for bacterial infection, was elevated 4.9. Next. We play the images. So he had a CT scan of the head, didn't show any acute findings. CT scan of the chest really didn't show any consolidation or infiltrate, nothing to suggest like a respiratory infection. And on the CT abdomen pelvis, he had the splenic cyst and signs of GI illness with dilated bowel loops or thickened bowel loops. Goes with gastroenteritis. Next. Again, something I want to bring your attention to is the sepsis mimics. So you have a patient with SIRS criteria, tachycardia or hypotension, increased respiratory rate. Remember, the definition of sepsis is possible source of infection. You don't have to have obvious or confirmed source of infection to call it sepsis. So if you meet SIRS criteria with possible source, you suspect an infection, then please treat as sepsis. And if you look at these sepsis mimics, other than probably the liver failure, if you have a cytokine release syndrome or a pancreatitis, anaphylaxis, DKA, adrenal crisis, you will never go wrong with sending cultures, giving IV fluid, and cover the patient initially with antibiotics. I mean, again, except for patient with liver disease where you might be cautious with giving IV fluid bolus, everything else, there is no significant harm with giving fluid, sending culture. And as long as there is no significant, antibiotic allergy, I think empiric antibiotic is not wrong. And I think from here, and then later on, of course, so the patient came in, again, completely altered, agitated, delirious. He was resuscitated from the time zero 1800, 1900, admitted to the ICU around midnight. By that point, patient was completely stabilized. His lactate cleared. His vital signs were stable. He was still altered. He did not require any vasopressors. Next morning, vital signs were normal. His lab results were trending down and electrolytes were corrected, and he was alert oriented back to baseline. And from here, I will hand it to Dr. Haddad.
Yeah, thank you, Dr. Al-Janabi, and thank you, Luke, for the excellent presentations. So on day 2, when we saw the patient had now positive blood culture for MRSA. And now the question is, where is this MRSA coming from? So we looked at the possibility that he has, any skin infection. We looked at the possibility of endocarditis. And we were not sure why he was also having vomiting and diarrhea. So there's a lot of things that we were going on, and we wanted to connect the dots. We asked for MRI of the back to see if there's any discitis. We looked for that, and it was negative. And we looked at the history and why this patient, young patient, comes in with MRSA bacteremia. We figured out he was self-injecting Dupixent in his abdomen, and probably that was the port of entry. Of course, that is also an immunosuppressive agent that will lead to MRSA bacteremia because the patient is immunocompromised. So we continued the antibiotics, and on the next, if you want to look at the next slide, we continued the antibiotics, and we asked for a TTE, which did not show any vegetations. A TEE was considered. However, the patient has eosinophilic esophagitis, and that was a contraindication, and we could not pursue that diagnostic study. We found that he is colonized with MRSA, and the rest of the tests were negative for any other infection. HIV was negative, hepatitis panel, Hep C and Hep B were negative, and the diarrhea and the vomiting with the C. diff, the C. diff was negative. That positive blood cultures continued despite the treatment with vancomycin. Therefore, we had to change the antibiotics to ceftaroline and daptomycin. And ceftaroline is a beta-lactam that has MRSA activity. Daptomycin is an anti-MRSA agent that's used for MRSA bacteremia, but you can't use it for MRSA pneumonia because of the binding to the surfactants, and it doesn't have activity in MRSA pneumonia alone. Next slide, please. The work of daptomycin and ceftaroline actually came out of SHARP. We did the first one of the first studies, as it was a prospective study. It was actually a small study. We enrolled about 40 patients, and we randomized them to Dapto or vancomycin versus daptomycin and ceftaroline. And when we looked at it, actually vancomycin versus daptomycin and ceftaroline. And when we looked at the outcome was significant in terms of, first of all, the clearance of the bacteremia, the duration of the bacteremia, and also the mortality. The mortality was significant, although the study was underpowered because we had only 40 patients. The daptomycin killing is enhanced by the beta-lactam, which is the ceftaroline. It actually increases the binding of the daptomycin to the membrane of the bacteria. Next slide, please. Of course, we would in any patient with a Staphylococcus aureus bacteremia, you need to rule out endocarditis, and you start with a TTE, transthoracic echo, and if that is negative, you pursue a transesophageal echocardiogram. Now, there are other instances where you need the TEE, especially if the patient still has bacteremia despite appropriate antimicrobial therapy. if the patient has a positive blood culture for enterococcus, streptococcus viridans, if the patient has a prosthetic heart valve or intracardiac device, pacemaker, ICD, if the patient has a new murmur or any signs of valvular dysfunction, if the patient exhibits any embolic phenomena, such as splenic infarcts, drainway lesions, or a stroke, or if the patient had any risk factors, like this patient, he was immunocompromised with the Dupixent, or has history of intravenous drug use, which can lead to bacteremias. And sometimes the TTE does not give you, is not helpful, and there is a high clinical suspicion of infective endocarditis, so you pursue a TEE. And sometimes we want to look for any complications of endocarditis, such as a perivalvular abscess or valve perforation or pseudoaneurysm. And sometimes we look for prosthetic valve dehiscence or vegetations. And sometimes we do a pre-surgical evaluation for patients who have bacteremia to assess structural abnormalities before cardiac surgery. So those are the indications of the TEE. And on another note, I would like to say why an ID consult was called in this patient. And that actually is a quality kind of measure. There was two studies that were done in the past that showed that if you consult ID on a patient with staphylococcal bacteremia, Staph aureus bacteremia, the mortality is reduced by 50%. So they looked at patients who had an ID consult, and the mortality was about 13%. And they looked at patients with no ID consult, and the mortality was at around 27%. And the conclusion from those two studies that were published in Clinical Infectious Diseases is that an infectious disease doctor would be looking at the source of the infection and try to reduce the rate of sepsis and reduce the complications, reduce mortality by putting the patient on the right antimicrobial therapy and the right duration, because sometimes the patient does not get the right duration of antibiotics for Staph aureus bacteremia. Next slide, please. So if you look at this patient, he was still spiking temperature despite the antibiotics, and that's why the antimicrobial therapy was changed to daptomycin and ceftaroline. And despite that, he was still continuing to have positive blood culture. We ended adding another agent. We added a carbapenem, ertapenem, based on data that showed that ertapenem in vitro can enhance the killing of Staph aureus, MSSA or MRSA. And actually, we had another work done here at Sharp Grossman Hospital where we looked at ertapenem combination with cefazolin against MSSA bacteremia, and that study has also been published and showed that there are better outcomes when you combine therapy for patients with MSSA bacteremia that are not responding to conventional therapy. Next slide, please. So the patient actually started improving after ertapenem was added, and the patient was on 3 agents. The repeat blood cultures finally cleared after, I think this is here on 216, after 4 days, and became afebrile. However, the CRP continues to be high. There was some LFT elevation that we presumed could be secondary to the antibiotics. And we treated the patient for 6 weeks with IV antibiotics because we did not have data to rule out completely infective endocarditis. That's one reason. The second reason, the persistent bacteremia that was going on for about 5 days or a week, we were concerned about that, and we thought that an endovascular infection could not be ruled out completely. Therefore, we opted to do 6 weeks of IV antibiotics. The patient was discharged in stable conditions. I saw him actually a few weeks ago, and he was still doing great. He's back to his job, and he now cleans where he injects himself with the Dupixent. He makes sure that He maintains sterility and not introducing any bacteria to his body. Next slide, please. And I will go back. I think this was my slide about infectious disease consultation. I can provide you guys with the references, but actually there is a few reasons why it's beneficial: mortality reduction, enhances antimicrobial stewardship, diagnostic evaluation and source control, and also reduces relapses. So these are very important pillars of why infectious disease consultation is important in MRSA bacteremia. And it's a quality measure. It's a quality kind of a measure that needs to be, we need to adhere to and we need to implement. Next slide, please.
I think
that's my slides. Thank you, Luke, and I'll turn the podium back to Luke.
Thank you. I just wanted to thank you so much, Dr. Haddad. I wanted to hand it off to Dr. Al-Janabi just to share the benefit of an intensivist consult for septic shock patients, if you'd like to touch on that.
Yeah, thank you, Luke. So, when we diagnose sepsis and severe sepsis, there's something called SOFA score, which is the sequential organ failure assessment. And just like even for a hospitalist or someone in the emergency department, or if you meet someone in your office and they look sick, there is something called a Q-SOFA. That's if the patient is hypotensive, tachypneic, with altered mental status. So 3 criteria for the Q-SOFA, or you do the whole SOFA score. And if there are any signs of end organ failure or damage, then this is an indication for ICU consult or admission to the ICU. So on the Q-SOFA, which is the hypotension, altered mental status, and tachypnea, if you meet 2 of them, that's considered high SOFA score, and the patient need to be in a higher level of care in an ICU rather than regular medical ward. And the reason for that is you have that window, which is the 6 hours or even 24 hours to resuscitate your patient, because after that, if you miss that window, no matter what resuscitation you do, then you will deal with the consequences of the end organ damage. And these, like, if someone, let's say, comes in with acute kidney injury and there is delay in resuscitation with IV fluids, and then they will head into acute tubular necrosis, renal failure requiring dialysis, and so on. So therefore, I think it's beneficial, and just keep in mind that when you meet the criteria for sepsis into severe sepsis, then you should seek an ICU consult because of the possible requirement for further resuscitation, vasopressors, and things like that.
Great, thank you so much. So I'll just go to our last part of our presentation, which is just a readiness for discharge. And I'm sharing this because one of the parts of SHARP as a whole's goal is to reduce pneumonia mortality and readmissions, which sepsis is a top reason that patients stay longer, so sepsis due to pneumonia. So one of the things we look at for readiness for discharge is, of course, the patient should be hemodynamically stable, so at least afebrile for at least 24 hours prior to discharge. We want improved inflammatory markers, so reduction or complete resolution of leukocytosis, normalized procalcitonin. We want to have good adequate source control, so no ongoing signs of uncontrolled infection. Ability to tolerate or back to their baseline nutrition status, so making sure that they're able to transition to PO antibiotics, or making sure that the appropriate midline or PICC line is placed so that they can continue their treatment when they're discharged. Also, we want to make sure that their respiratory status is at adequate functioning or at their normal baseline. So if they're on 2 liters of oxygen here and at home, that's the same. And also making sure that their mental status and functional status is at a stable state or at their baseline. A lot of the great work that our case management does is making sure that they have good support at home, making sure that they have access to care after discharge. We also need to make sure that our staff are giving them appropriate discharge instructions for their home environment, when to follow up with their primary care doctor, if they need to see a specialty provider, that they should have that instruction before they leave. And then a good follow-up plan. How are they going to get to their physical therapy? Are they going to come home to their home? So those are all things that help make them successful for discharge beyond the walls of the hospital. So in summary, sepsis is a very highly complex disease process, and there's a high associated mortality rate. There have been recent advancements that have improved outcome, but it still has a very large disease burden, especially in hospitalized patients. We do have measures that help provide treatment modalities, but that's not a cookbook medicine. There is a degree of precision medicine that's needed for patient-centered care. Antimicrobial resistance is on the rise, so we need to reassess the need for antibiotics frequently. And really, as Dr. El-Janabi and Dr. Haddad mentioned, early specialty consultation does improve outcomes and helps with quality care. And we need to make sure that patients are equipped with the tools to make them successful for discharge home, so they can go to their normal life. So open to questions, and thanks again, Dr. Haddad and Dr. El-Janabi, for co-presenting.
Thank you, Luke.
Thank you, Luke.
Dr. Kamiar, we see your hand raised.
Well, thank you, guys. It was a fantastic presentation. I wish we can do a lot of more case presentations from our own medical staff. That would be fantastic. I just had also a question as far as, actually one comment, but these injections that we gave for such as Dupixent, or in the field of primary care, a lot of injections, intramuscular or subcutaneous, for different hormones and stuff. I think we have to be very vigilant about telling the patients to make sure that the needles and the area that they inject are very clean. So I think that is one thing that we should really take this, because as you pointed out, Dr. Haddad, that it's Dupixent, such, it's autoimmune medication and reduces immunity, but at the same time, if you inject bacterial contents of the skin into the gut, it would be very difficult to take care of. So that's one thing. The other thing that I just wanted to make sure that eosinophilic esophagitis is, when we dilate the esophagus, it does cause significant wear and tear in the esophagus. So people who have these dilations should be warned about possibility of infection, and make sure that they are instructed as far as how to take care of themselves. And sometimes we may have to use prophylactic antibiotics if needed. The other question that I had is whether there's any effort to make these antibiotics that we are now using somehow resistance or developing resistance. I don't know how to put that, but is there any effort to make these antibiotics such that they don't develop resistance towards them?
So I can take that question. I think that we have a robust antimicrobial stewardship program that focuses on utilization and appropriate antimicrobial therapy. We have added actually diagnostic improvements where we are using Verigene for a quick identification of bacteria. In addition, we have actually focused.
Your sound is a little bit distorted.
Can you guys hear me?
Mm-hmm.
Yeah. Sorry. Yeah. So quick identification of bacteria, making sure that we have appropriate antimicrobial therapy after we have positive cultural results. The antimicrobial resistance is a big concern, and what we focus on is when sepsis, we start patients on antibiotics, and then after 48 hours to 72 hours after the diagnostics come back, we de-escalate antibiotics and try to put the patient on narrow spectrum antibiotics that work, appropriate antibiotics. So that's how we do it. Also, the duration of antibiotics have come down. In the past, we used to treat, for example, community acquired pneumonia for 7 to 10 days. Now 5 days is adequate. And even healthcare-associated pneumonia, it's less and less. UTIs, the same thing. We also focusing on the distinguishing between asymptomatic bacteriuria and UTI, and the fact that a lot of, for example, primary care physician prescribe antibiotics for positive cultures without symptoms, which adds more to the antimicrobial resistance. We've also, noticed that also in the rehab when patients are, for example, paraplegic and they're getting urine cultures just because of a change of urine color or smell, which really does not define UTIs. So there's a lot of things we're doing on multiple levels, multiple fronts to try to pare down antimicrobial resistance.
Thank you. Thank you very much.
No problem.
Any other questions, please feel free to unmute yourself and ask them or type them up in the chat box. If questions do come to mind later, we'll make sure to get them, pass them along to the team here. Dr. Kamir, I see your hand raised again. Yes.
Yeah. Apart from MRSA, what else is becoming an issue for significant resistance and causing a lot of clinical issues?
So in terms of microbiology in the hospital, we're focusing now on, for example, the multi-drug resistant gram-negatives. So Pseudomonas aeruginosa is one of them, the Klebsiellas, and the Nudales, Metaloclinases. So there is now rising gram-negative rod resistance is an issue, and we're trying to incorporate guidance into complicated cases. We're seeing more and more length of stay due to improvement in care, and I think moving forward in the future, what we will see is we'll see patients who are in the hospital for a longer time because now we have a better strategies of keeping people alive, but at the same time, we're going to have more issues with gram-negative rod resistance. So gram-negative resistance is an issue, and will continue with us for quite a while. Also, the resistant Candida auris, which is resistant to all antifungals, is an issue. Most of the cases are colonized with it, but it's also a nightmare for hospitals. C. diff colitis is, of course, proportional to the antimicrobial use. So the more antimicrobial use in the community and in the hospital, then you will see more cases of C. diff colitis. So those are the issues that are keeping us at night. But for the most part, I think the antimicrobial stewardship program at Sharp Grossman has incorporated the pharmacists, and we have an excellent ID pharmacist, Marie, and we have Luke, who's also supervising the sepsis program. So really have gotten a boost in these interventions, and we have gotten better and better over the years. And I think Sharp Grossman Hospital now, as we see it, has been leader in quality measures and healthcare outcomes.
Fantastic. Great. Thank you very much.
I see Sarah has her hand up. You're on mute, Sarah. Oh. Oh, she says that was a mistake. Okay, no worries.
I just want to pose a little bit more discussion. What is the situation with the use of antibiotics in our community now, with all this basically making the knowledge popular that too much use of antibiotics are not good? Have we made any progress in that, not only in the Sharp healthcare area, but also the rest of the community?
There's a lot of CDC public health, programs on antimicrobial stewardship. There's actually, I hope, still up and running. There's something called TRAIN, TRIAN, and it's actually a CDC website where with health, where there's, where you can get trained and how properly use antimicrobial therapy. There's also the asymptomatic bacteriuria has made it to the primary care conferences, and people talking more about asymptomatic bacteriuria. And not every positive urine culture needs to be treated. And taking a deep dive on these cases and not just treat everyone just because they have a positive urine culture. So that is where I think the improvement can come from, trying to reduce antibiotics for these indications. There's a question in the chat says, are there any inroads with UCSD and their IPAT the FASH program? We haven't sent any patients to UCSD for I would call it pan-resistant isolates through the FASH program. I know they have done impressive work on that under the care of Dr. Schooley there, Chip Schooley, and I think maybe it's future topic to be talked about. Maybe that's one of the topics Dr. Kamiar can suggest for future grand round to talk about the FASH program at UCSD. So the FASH is basically trying to change the DNA of the bacteria to make it from resistant, changing it to susceptible bacteria by incorporating a phage. And a phage is kind of a virus that carries a DNA and lands on the bacteria and changes its DNA. So I see that from Luke. He's putting that in the chat, and it's actually, it's actually a great innovation. I think we haven't had a case that requires that, but I think it's something that's upcoming and going to be very helpful in cases where
Sure.
there are options.
Sure, we'd be happy to do that. Very good. All right, guys. Thank you again. Thank you very much for this lovely forum.
Okay.
There's another question in the
Thank
chat from Adola. New comments on fungal infections, especially candidas. Has this been a problem? Are these Candida infections resistant to common antifungals. I will say we do screen for Candida auris, especially amongst, you have to have criteria, but one of them is particularly for skilled nursing patients. So we see that that's highly resistant to your standard antifungal treatment. So that's something, and it's very, very virulent. So once we identify a patient with Candida auris, we have to isolate them and make sure that we have good infection control processes in place. So I don't think we see a lot of cases, correct me if I'm wrong, Dr. Haddad, but we do screen a lot.
That's correct. Yeah, we screen them, they're asymptomatic, and most of these cases, unfortunately, are patients who are with terminal illness, and they are in the hospital for a long time, and sometimes we can't, unfortunately, the patient needs to be in hospice or palliative care. The family states they want everything to continue the same, and the patient continues to be in the hospital, and they just harboring these resistant bacteria and resistant fungi. Yeah, so it's a problem, but we haven't seen any candidemias or sepsis related to these Candida auris colonizations.
Thank you, Jason, for organizing this again. And I think this is our spring last session, isn't it?
Yeah. Can I say something, Dr. Kamiar? We are going to have a symposium for infectious diseases on November 1st. And it's going to be the first ID symposium for SHARP. Me and Dr. Sakolos are working on it. And it's going to have excellent speakers. We will be having a speaker on gram positives and speaker on gram negatives and speaker on tuberculosis and speaker on the DNA diagnostics on DNA testing, the Carious test that we are using more of it. So.
Great, it's excellent. To make sure it's popularized, and basically we are all informed of it.
Yes, we will send a flyer and we will send emails as time comes closer to the symposium.
Okay.
It's going to be in the Innovation Center. Yeah.
Great. Jason, any other things, other information that we have shared?
I'm sorry, say it again.
I was asking Jason if there's any other information.
Oh, can you hear me?
Jason?
Sorry.
Yeah.
Apologies, my headset's going.
Any other thing that we have to know? This is our last spring session, right?
Going a little crazy right now. Yes, so this is our last session, and we will be returning September 18th.
Very good. Excellent. Thank you, guys.
Yep. So thank you all very much for joining us today. I do see a couple questions. Oh, thank you, Anthony, for handling that. Please remember to text your attendance to 858-247-3111. The activity code for today is 19693. Thank you all for your time and knowledge today.
Thank you.
Thank you.